Good evening, everybody. My name is Raed Dahash. I am a consultant in criminology Aziz Medical in National Guard in Riyadh. Today is World Diabetes Day. So in this day, we are celebrating the 100 years of discovery many medications. These medications, it's treating our diabetic patients. The first one discovering the first medication, his name is Prof. Benting, and Prof. Benting, he's the one discovered the first medication of diabetes. That's why they call this, the IDF and WHO, they decide that this date is to be World Diabetes Day, and this date is a birthday of this professor, the birthday of this Professor Benting, and they chose this date to be the World Diabetes Day. Today we'll talk about many, very important medications and very important condition of disease. It's a metformin. It's one of the oldest oral medications and one of the very important medication to treat our patients. So as you know, diabetes, it's affecting many people, and there is 1 out of 5 in elderly, they're age 65 and above, they're having diabetes. And the people with diabetes, 1 out of 2, unfortunately, they are undiagnosed, and this is worldwide. And the problem is this will cost our country and all the world a lot of spending of dollars, and also it will cost in mortality and morbidity about 4.2 million people death from either from diabetes or from its complications. And there is 1 out of 6, they are living birth as affected by diabetes during pregnancy, what we call a gestational diabetes. And there's 374 million people, they are at increased risk of developing type 2 diabetes. And this is very huge, to be honest with you. In Saudi Arabia, for example, if we look for our number, we have 1 out of 6 adult, around 3.5 million people they having type 2 diabetes. And it's costing our country about 20 billion riyals. And this is very huge and affecting our country. The type 2 diabetes, usually it's not start sudden, but they having a lot of things before that started, what we call it pre-diabetes phase, like impaired fasting or impaired glucose tolerance test, or the patient having hyperinsulinemia. So we are usually missing the pre-diabetes, and the patient come to us with one of the problems, and then so for example, he came with obesity or pregnancy, or having problem in his body, then we check for that and we discover this. And this is wake-up call for all of us to act on this patient to prevent this patient to having diabetes. So we will talk more about the pre-diabetes. What's the laboratory abnormalities, or what's the disease to be treated? So the prevalence of pre-diabetes is increasing very hugely. For example, in 2017, there is 352 million people having diabetes, which is affecting 7.3%. And in 2045, there is 587 million people having diabetes, which is almost 8.3%. If we focus on MENA region, we have 33.3 million people having diabetes, and there is 63.9 million expected to be in 2045 having diabetes. So about 9.4%. And this is MENA region, the number is more than the world. For example, the prevalence of pre-diabetes among the male in Saudi Arabia, the estimation was 27%, which is very huge and very high. Now, if we try to look for our figures in Saudi Arabia and UAE, in Emirates, we find that both of us, the 2 highest adult prevalence rate of diabetes in the world. In Saudi Arabia, about 18.6%, and in Emirates, about 15.6% respectively. So the prevalence of diabetes and pre-diabetes is increasing, either in UAE or in Saudi Arabia. So the intermediate metabolic state of hyperglycemia with glycemic parameters above the normal, they're having threshold for diabetes. And how we figure out, either we found this patient having impaired glucose tolerance test or impaired fasting glucose. So the both abnormality of these, it gives us hints to those patients will be pre-diabetes, and its need from our side recommendations and treatment to prevent those patients to be having diabetes. If we try to figure it out, the fasting blood glucose less than 100 we calculated as a normal. From 100 to 125 we calculated as a pre-diabetes. More than 125 we consider those patients as diabetic patients. Now, if we talk about 2-hour plasma glucose tolerance test, those having 140 and below, they are normal. From 140 to 199 milligram, they have impaired glucose tolerance. More than 200 and above, they are having diabetes. Hemoglobin A1C, 6.5 and above, diabetes. From to 5.7, they call impaired glucose tolerance test. Below than that is normal. So there is alarming of pre-diabetes, and there is many recommendations from CDC or other institutions or societies. They try to define the pre-diabetes, and they try to see how much the progression. And by the way, the numbers during the years is increasing. And now the ADA, they start to be more strong. They said, ADA say weight loss can also be considered for pre-diabetes. And before that, they said keep monitoring hemoglobin A1C for those patients. And before that, they said you should give the medication for diabetes in those patients with pre-diabetes. In 2007, for example, they said you should begin metformin for some pre-diabetic patients. So the ADA gradually they start to be recommended more to treat those patients and to start with them aggressively to prevent the progression. Why that? Because there is 5 to 10% of individuals with pre-diabetes, they develop diabetes annually. And there is 70% are expected to develop diabetes within 10 years. So individual with impaired fasting glucose or impaired glucose tolerance test, they are higher risk of developing diabetes with 10 to 15% compared with individual only with one of these conditions, 5 to 10%. Now the pre-diabetes, they are meeting the definition of the disease. And the pre-diabetes, it's causing impairment the normal functioning of some aspects of the body. They also having economic burden, impaired quality of life, they causing harm and morbidity, and having characteristic signs and symptoms for those patients. Usually, when we discover the patient having diabetes, there is 5 or 10 years before that, the patient having what we call the pre-diabetes, and the problem is started before that. So the beta cell functioning start to come down, the insulin resistant insulin secretion start to be up, the postprandial glucose and fasting start to be up, so the microvascular and macrovascular complication or type 2 diabetes start to be increased. So the people with pre-diabetes at increased risk of microvascular and macrovascular complications. And if we take it one by one, for example, the retinopathy, there is 8% of individuals with pre-diabetes, they having diabetes retinopathy start with them. And there is 13 to 11% of people with impaired glucose tolerance test or impaired fasting glucose, they're having what we call it polyneuropathy, respectively. The neuropathy, about 17% of individuals with impaired fasting glucose have chronic kidney disease. And this is a very significant matter and point to be considered for those patients. Cardiovascular disease is increased with pre-diabetes, and we know that. So there is 10 to 14% there is increase comparing with normal, with those with normal glucose tolerance test. And the cardiovascular mortality associated strongly with impaired fasting and glucose tolerance test, and the risk of mortality start to be increased for those patients. So IGT, impaired glucose tolerance test, is stronger than impaired fasting as a predictor of macrovascular complications. Now, if we try to ask ourselves what the risk factor of pre-diabetes, especially in those asymptomatic, and when we should consider to investigate them, those having age from 45 years without other risk factors, those having cardiovascular disease or family history of type 2 diabetes, those having overweight or obese, we should consider them and we should investigate them. Those having sedentary life, if there is a member of at-risk ethnicity group like Asian, African American, Pacific, and some countries they having more risk to having diabetes. Those having HDL less than 35, or those having high triglyceride more than 250, we should screen them. Those having impaired glucose tolerance, impaired fasting, metabolic syndrome, those with PCOS, acanthosis nigricans, and those with NAFLD, those with hypertension, blood pressure more than 140/90, or those on treatment therapy. History of gestational diabetes, delivery of big baby for 4 kilograms and above, those with antipsychotic therapy, for example, schizophrenia, severe bipolar disorders, those in chronic corticosteroid exposure, those having sleep disorder in presence of glucose intolerance, including obstructive sleep apnea, chronic sleep deprivations, and those having night shift occupational. So there is a question always. The test should be considered in those overweight or obese in adult, and if they having one or more risk factors, like first degree relative having diabetes, high risk race or ethnicity, history of chronic cardiovascular disease, those having high blood pressure, those having HDL low or triglyceride is high, women with polycystic ovary, physical inactivity, and those associated with insulin resistant like severe obesity or acanthosis nigricans. Patient with the pre-diabetes and should be tested yearly. Women who are diagnosed with gestational diabetes have lifelong testing for at least 3 years. All other patient tests should be begin at age 45 years. If the result normal, test should be repeated at minimum 3 years interval, with consideration of more frequent tests depend on initial result and risk status. So again, why to screen for those patients? Better patient outcome, cost effectiveness, and improve population health, and help making the change from reactive medicine to preventive medicine. And there is many calculator to use, the one of them in ADA. Just you can put the age, male or female, and they will ask certain questions like physical inactivity, having GDM before or not, having family history, and they calculate it as a point, and after that they will told you this patient is low risk or high risk for type 2 diabetes. So there is several factors associated with questionnaires, and there is many calculators to be used. Maybe one of them is Canadian calculators, and they try, if you see the calculator, they add age, sex, ethnicities, relative with diabetes, waist circumference, and PMI is also very important. Those having high blood pressures, some guidelines with physical activity, some not putting physical activity. In Canadian, they put more restricted criteria like vegetable, fruits eater, history, phrasing, blood pressures, level of education, general health, and smoking, because as you know, there is direct or indirect habits to increase and to give you a risk for type 2 diabetes. There is one word from Thomas Edison. They said the doctor of future will not prescribe the drug. Instead, he will awaken the interest of the patient toward his body, as well as the reason and possibility of preventing the disease. So now everybody moving to prevention rather than to start a treatment. So the pre-diabetes treatment goals to normalize the glucose level, to prevent or delay the onset of diabetes, to preserve the beta cell functioning, and to prevent or delay microvascular and macrovascular complication, and ultimately to reduce the cost of diabetes care, and also the manage of the common pre-diabetes comorbidities like obesity, hypertension, dyslipidemia, cardiovascular disease, and chronic kidney disease. So the question now, how can we prevent diabetes? And how the guidelines implementing that and tell us what to do. So healthy diet, one of the cornerstone, physical activity, and weight loss. This is the 3 points need to be added. So in the ADA, they written very clearly that the patient with pre-diabetes should modify their lifestyle, including initial attempt to lose 5 to 10% of their weight, if overweight or obese. And also, can they do moderate physical activity, walking at least 150 minutes per week? So the physician should recommend the patient participation in organized lifestyle changing program with follow-up when available, because the behavior support will benefit the weight loss effort. Patients with pre-diabetes should be referred to intensive behavior lifestyle intervention program on diabetes prevention program to achieve and maintain 7% loss of initial body weight and increase moderate intensive physical activity to at least 150 minutes per week. So what's the programs? We have 3 programs. Diabetes prevention program, it's a USA. Their baseline BMI 34, and the relative risk reduction in those category was 58%. And there is diabetes prevention study in Finland, also they showing that the relative risk reduction about 39%. And there is one study in China, they call Day-from MERK, also they found those patients, the relative risk reduction was 51%. The baseline BMI was ranging from 25 to 34 in those studies, and the number of patients enrolled and the duration was variable, but one of them was very extensive, about 5 years. So now what's the efficacy of lifestyle changes in the pre-diabetes? So during the trial, the risk of diabetes was reduced by 58% in intervention group, and the reduction in incidence of diabetes was directly associated with life change. So the lifestyle intervention group is very important when you compare it with the control groups, and the lifestyle modification is very important in those patients with pre-diabetes. So what about the drug to be used to preventing diabetes? There is a recommendation from ACE and from ADA. In the ACE, the American Association of Clinical Endocrinology, they said in addition to lifestyle modification, the medication including metformin, acarbose, or TZDs should be considered for patients who at moderate to high risk for developing diabetes, such as those with first degree relative with diabetes. Metformin for prevention of type 2 diabetes should be considered in those with pre-diabetes, especially in those with BMI more than 35 and those their age less than 60 years and women with prior gestational diabetes. In IDF, they said, they recommend that when the lifestyle intervention alone has not achieved the desired weight loss and improving glucose tolerance goals, metformin in dose of 250 to 850 milligram PID should be considered as a diabetes prevention strategies, particularly in those their age less than 60 with PMIs high more than 30 and fasting glucose more than 110 who's not having contraindications. So now there is many study talking about the prevention of diabetes. One of them, diabetes prevention program, they're using metformin, and the STOP NIDDM, they're using acarbose, and the DREAM, they're using rosiglutazones, and ACT now, they're using pioglitazones. So now if we try to look for those having diabetes prevention program, the DDBP lifestyle changes, and we try to compare it with metformin, we find a lot of study talking about that. We know that the effectiveness of lifestyle modification is very important, and the result was very significant. But if you can see here, those having BMI more than 35, using metformin and lifestyle modification, they are almost the same. But in those less than 30, from less than 35 or that's less than 30, the lifestyle modifications was risk reduction in metformin. We always told our patient we can use both lifestyle modification and metformin at the same time. Metformin by itself, it's also reducing the risk of diabetes by 31%. And we know that the lifestyle modification, it will decrease about 58% relative risk reductions. And this is very significant also. So very long-term efficacy of lifestyle modification and metformin to reduce the incidence of diabetes in the population with high risk was very high. In metformin was almost 18%, and in lifestyle modification about 27%, which is very huge. Also, the metformin, it will reduce the risk of incidence of new onset of type 2 diabetes. So it very significantly and about to decrease 40% versus placebo. So also the metformin, they are restoring the normal glucose tolerance and they make those patients as normal for them. Also, the metformin showing that it reduces significantly risk of progression from pre-diabetes to type 2 diabetes in population in USA, India, and China. So we have now a lot of studies talking about that. And when we decrease the progression of pre-diabetes to diabetes, it was associated with 28% lower risk of microvascular complication. If we try to see the ACE algorithm, they said if your patient having from the fasting blood glucose from 100 to 125, this is impaired fasting. If having 140 to 199, this is impaired glucose tolerance test, and they call it this is metabolic syndrome. So they start with lifestyle modifications for them. And if they're having cardiovascular risk factors, they treat them either hypertension or diabetes or dyslipidemia, and they enroll them in weight loss program. Then after that, if they are normal, that's good. If not, if they are over diabetes, you take them to diabetes intervention program. Now, if this patient having fasting blood glucose more than 100 and 2-hour postprandial is high, so they start them in intensify weight loss therapy. Then after that, if they are not improved, they use low-risk modification like metformin or acarbose, and they are considering, if not normalizing, to add GLP-1 or TZDs with cautions. So now, if we try to look at the medication and the follow-up intervention, or how much the reduction in type 2 diabetes, the metformin in the studies, follow-up studies, they follow them in 2.8 years, and they found the reduction about 31%. In acarbose, they follow them in 3.3 years, and the reduction of risk in type 2 diabetes about 25%. In bioglitazone, the follow-up period was 2.4, and the reduction was 72%. Rosiglitazone, about 3 years follow-up, and the reduction was 60%. Orlistat in weight reduction management, 4 years follow-up, and the reduction was 37%. Phentermine and topramates, they are follow-up period 2 years, and the risk reduction was 79%. Bariatric surgery for follow-up at 10 years, 75% reduction in those category group. So there is one of the study by, it's in our country, they're talking about reversal of pre-diabetes in Saudi adult. The results from 18-month lifestyle interventions. It was randomized, multi-center trials, patient with pre-diabetes, their age from 25 to 60, 180 individual, they having lifestyle intervention compared to control groups. They found there is 52.1%. They are intensively lifestyle modifications, and the conclusion was tailoring lifestyle intervention is effective and reverse the pre-diabetes at least for a year among Arab adults with pre-diabetes. So the conclusion, the pre-diabetes is preventable and significantly increase the risk, life, and progression to type 2 diabetes. 5% of individuals with diabetes, unfortunately, they develop diabetes, with up to 70% eventually developing diabetes. The pre-diabetes cardiovascular disease, the insulin resistant is a power of prognostic indicator for increased risk of diabetes or cardiovascular disease. The pre-diabetes increased risk of adverse cardiovascular event like MI, stroke, cardiovascular death. Pre-diabetes increased risk of microvascular complication like retinopathy, nephropathy, and neuropathy. Pre-diabetes should be managed to prevent progression of impaired glucose tolerance, impaired fasting to over type 2 diabetes. Globally, the diabetes is very huge. And if you try to see the Middle East having a big share in Middle East and North Africa, about its red color, so how a lot of people they having increased risk of diabetes. Worldwide, we having a lot of patients having diabetes, and unfortunately 46% they are undiagnosed. But in our region and our country, unfortunately, we having extra seats and front seat for type 2 diabetes patients, and we have a lot of cases, and the increasement more than doubling in our country comparing with globally. Also, unfortunately, Saudi Arabia is one of the top 10 countries in the world having type 2 diabetes, and maybe it's one of the biggest country in the Gulf in GCC having type 2 diabetes about 24%. The prevalence of diabetes in Saudi Arabia increasing. If you try to look for 1982 and compare it with 2009, there is increased risk of incidence by 1% every year. Insulin resistance is the hidden dangers for all of those patients. We didn't know about them. Some of them, they come to us in the clinic, and some we found them incidentally. Failure to reaching the glycemic control is worldwide. A lot of countries, they don't having control of their diabetes. Not only us. If you try to look in England, Thailand, USA, Mexico, a lot of countries, Scotland, a lot having good percentage of those patients, as we said before, they are undiagnosed. Even those having diagnosed, they are untreated, they are uncontrolled, and so on. Only if you can see here, the blue color is those patients treated and controlled. The other color, the orange color, they are treated but they are uncontrolled. The bright blue color, they are diagnosed and they are untreated. And the red color, they are undiagnosed, unfortunately. The result of the failure to reaching glycemic target is worldwide. When we take hemoglobin A1C checked, we see a lot of countries like Belgium, France, Germany, Ireland, Italy, Netherlands, Sweden, UK, they having uncontrolled. Insulin resistant and beta cell functioning started before the diagnosis, and the patient usually starts with hyperinsulinemia and insulin resistant and mild postprandial hyperglycemia. Then after that, with the time, the beta cell functioning start to be failure and start to be down, then the postprandial hyperglycemia start to be increased, and the fasting hyperglycemia start to be there. So there is failure 50% of beta cell functioning cells, 4% every year. So after 10 years, there is 40%, another 40% to be lost. Now, why are we working to decrease that? You know, there is, if you are decreasing only 1% in hemoglobin A1C, you're decreasing a lot of microvascular and macrovascular complication. So only decreasing 1% in hemoglobin A1C, decreasing 37% in microvascular disease, decreasing 43% in peripheral vascular disease, decreasing 12% in stroke, 16% in congestive heart failure, 19% in cataract extract, and 21% in death related to diabetes. The challenges in achieving glycemic control: less aggressive treat to target approach by some clinicians, suboptimal use of available therapy, inavailability of any single agent to address all the core defect of type 2 diabetes, and potentially for increased side effect with using multiple agents. And there is suboptimal adherence of lifestyle measures. A lot of patients, they say, it's easy to say lifestyle, but it's difficult to do. And there is underuse of medication results because of cost or complexity of the therapy. Now, the retinotherapy and albumin UA is very significant decrease in a lot of microvascular studies like UKBDS, DDCT, Accord study, Advance, and VEDIT. However, in UKBDS and DDCT in the long term, there is showing that there is decreasing in microvascular complication like cardiovascular disease. Also, in UKBDS in long-term follow-up, it's showing also it's decreasing the risk of mortality. So what's the target? In IDF, they said the target for type 2 diabetes is hemoglobin A1C less than 7. In ADA-AST guidelines, also they said less than 7 for most of the patients. In ACE guidelines, they said less than or equal 6.5 for healthy patients without concurrent illness and risk of hypoglycemia. And they accept more than 6.5 for those patients with concurrent illness and risk of hypoglycemia. The glycemic target for non-pregnant ladies should be hemoglobin A1C less than 7. And we should also try to, by reducing less than 7, it will reduce the microvascular and macrovascular complication. The pre-prandial test should be from 180 to 130. Postprandial blood glucose should be less than 180. Individual target based on age, lifestyle expectancy, comorbid condition, diabetes duration, hypoglycemia status, individual patient concentrations, non-cardiovascular and advanced macrovascular complications, more or less strangest target may be appropriate if can achieve without significant hypoglycemia or adverse effect. More strength target, less than 6.5 in ADA, less strength target if those elderly and having comorbidities, less than 8%. Metformin. Metformin, it's decreasing in hemoglobin A1C about 1.2%. Insulins, also it's reaching up 1.9%. GLP-1 agonist decreasing 1.1%. DDB4 0.7%. Alpha glucosidase inhibitor 0.7%. TZD is 0.9%. Sulfonylurea 0.7%. Glinides 0.6%, and SGLT2 inhibitor 0.8. And I want to highlight one point here. Usually the studies, they take cutoff point is 8.8 to 8.2, but more higher in hemoglobin A1C, more reductions. We should discuss with the patients, we should sit with the patient, and we individualize the patient toward their and address the risk factors. So we should look for blood pressure, lipid control, smoking prevention and cessation, weight management, physical activity, and healthy lifestyle choices. Metformin is one of the old goal treatment for type 2 diabetes. It's working through multiple mechanisms, working in the liver, working in the muscle, and working in the pancreas. It's impaired the insulin secretions. The hyperglycemia happening through impaired insulin secretions and increasing glucose productions and decreasing glucose uptakes. And metformin tried to enhance the decreased glucose uptake and inhibit increased glucose production. And in this way, it will decrease the risk of hyperglycemia. Also, anti-hyperglycemic effect in metformin, if you try to see the baseline and 3 months after, you will find the blue color is the baseline, the yellow color is after using metformin. So it will decrease the fasting blood glucose, it will decreasing hemoglobin A1C, and it will decreasing the fasting insulins. Metformin doses, more increase in the doses, more decrease in hemoglobin A1C. You can see 100 better than 500, 1500 is better than 1000, and 2000 better than 1500 milligram. Also, metformin, its effect on hepatic glucose productions. So you try to see the control people in the yellow color and diabetic patient before metformin in the yellow color, and the red color diabetic patient after metformin, and there is significantly improve their glucose metabolism. Also, the metformin, it decreasing the fasting, improving the fasting insulin level. So metformin is one of the insulin sparing effect. It will not working in the pancreas, but indirect effect, it will causing decreasing the blood sugar in those patients and improving their plasma insulins. Also, metformin, it will be in some patients decreasing weight. However, most of the patients, they will make them weight neutral, so they will not gain more weight. A lot of other medication like insulin, like sulfonylureas, it will increase the weight. Then when patient increase weight, he require more insulins, and when he require more insulins, patient, his hemoglobin A1C, it will be more not controlled. As we said before that, metformin either to control the weight or decrease what we call it weight neutral. Sulfonylurea, it will increase the weight up to 4 kilograms for each patient. Also, metformin, it will change the body composition in the weight, the BMI, total body fat, total subcutaneous fat, and abdominal subcutaneous fat, visceral fat, and lean body mass. So it will affect all the bodies. It will be decreasing the mainly in visceral fat and abdominal subcutaneous fat and subcutaneous fat, total body fat, and BMI and weight. It will help the patient to change their body. The clinical outcome in weak UPDS, metformin in intensively groups, it decreasing diabetes-related death about 42%, all-cause mortality about 36%, any diabetes-related endpoint 32%, MI about 39%, and stroke about 41%. And these numbers is better than sulfonylurea in the same study. What about legacy efficacy of earlier metformin therapy? So diabetes-related death, it will be decreasing about 42%, and all-cause mortality, it will be decreased. MI, as we said before, it will be decreased. So the cardiovascular complication, it will be decreased for the patient, and survival rate, it will be increased for the patient. The metformin is frequently underused. If you see all the countries, they are underused, not in the clinical practice as would be used in the UKBADS studies. And the dose-related side effect of metformin is very available, and most of the patients, they will complaining of more increase in the dose, more increase in GI side effect. But only a lot of patients, when we start with the metformin at the beginning, they will having that, but after a while of the time, it will be disappeared. But some of the patients, less than 10% of them, they will discontinue the medication. They cannot tolerate the side effect. That's why they having a new formulation. We call it XR, and XR, it will slow or decrease the gastrointestinal side effect. And we have 500, 750 milligram, and 1,000 milligram XR tablet. It will decrease the side effect, and having absorption fast, 30% within maybe 0 to 2 hours, and bioavailability about 60%, and they having dissolving in within 15 minutes. So they will have not like the standard one, and the XR, it will be more released and extended release in the body, so it will decrease the side effect, and the sustained release will make the absorption slower and longer, and make the patient benefit better. So optimizing metformin with increasing more doses, it go more glycemic benefits, more clinical benefits, and tolerability and safety for the patients. Add on therapy like sulfonylurea, TZDs, DPP-4 inhibitor, GLP-1 agonists, SGLT2 inhibitors can be benefit and can decreasing in hemoglobin A1C, but every medication having advantage and disadvantage. Sulfonylurea, long experience with microvascular risk reduction and lower cost, but the disadvantage is hypoglycemia and weight gain. TZD is having no hypoglycemia, but it's raising HDL, the advantage. The disadvantage, weight gain, edema, heart failure, bone fracture, and raising LDL cholesterol. DPP-4 inhibitors, there is no hypoglycemia and well tolerated. The disadvantage is urticaria, acute pancreatitis, heart failure, hospitalizations, which is not high, but very rare. GLP-1 agonist, no hypoglycemia and well tolerated. GI side effect is high. Acute pancreatitis, those patients with thyroid neoplasm, we don't recommend them to take it. SGLT2 inhibitors, no hypoglycemia, and they have a benefit in weight loss and blood pressure, but they having gastrointestinal infection, polyuria, and volume depletion hypotension is a query. Raising LDL cholesterol, also one of the problems. So your clinical judgment and important clinical assessment, it will reduce the risk of weight gain, reduce risk of hypoglycemia, severity of comorbidities, and long-term safety of the new agents. Cost of the medication to the patient also is very important. So if we try to talk about metformin contraindications, type 1 we don't use with them, acute or chronic metabolic acidosis, including DKA, those history of lactic acidosis, those having hepatic dysfunctioning or lactic acidosis. GFR is those having already less than 70s, we don't use for them, hypersensitivity, and we should discontinue when there is severe infection, trauma, surgery, severe dehydration during pregnancy, and breastfeeding as per Saudi FDA recommendations. Metformin and iodine contrast, we always ask about that. We said you should hold the metformin before the iodine contrast procedure if GFR from 30 to 60, if the patient having liver disease, alcoholism, heart failure, and intra-arterial contract is used. Recheck the GFR 48 hours after the procedure and restart metformin if the renal function is stable. Diabetes management, you should know that it's multifactorial. There is educational, there is smoking and lifestyle modification, there is blood pressure control, there is control blood sugar and aspirin, statin. So there is multiple intervention. We should address all of that to protect our patient and to prevent them from complication. At the end, thank you so much for your listening. Thank you, Merck, to conducting this important lecture at important day as Diabetes Day, International Diabetes Day, and we all of us celebrating this day at the end to treating our patient, to reaching our goal. Thank you so much for your listening again, and see you soon, inshallah.
السلام عليكم. هناخذ الأسئلة الآن. We have a lot of questions. The first question came to us: how the complication in women with polycystic ovary can be minimized. As you know, the polycystic ovary, the problem in the polycystic ovary, it's related to what we call it insulin resistant. So we can minimize the polycystic ovary symptoms by taking metformin. Metformin is one of medication. It can help to reduce the sign and symptom of polycystic ovary and to decrease the insulin resistance. Also, we ask the patient usually to take to reduce the carb as much as they can. Some patient we need oral contraceptive pill to regulate their cycle. If the hirsutism is a problem, we ask them to do a laser therapy. Some patient we add for them some of the medication like spironolactone to help their cycle and to help their symptoms. There is another question: what about the role of the GLP-1 agonist in the pre-diabetes? As you know, in the pre-diabetes, we recommend the patient to take to do diet and exercise first. Then after 3 months, we try to reassess them. Then after that, we start with a small dose of metformin. And after 3 months, we try to reassess again. We double the dose of metformin. If not improve, we consider, as you know, the ACE guidelines now, they consider to add GLP-1 agonist to those patients, and it will help them a lot decrease their weight, and especially if they are obese, and at the same time to control their pre-diabetes. The GLP-1 agonist is one of the medication can be used to treat those patients pre-diabetes, especially if they have overweight or obesity. We have another questions about what's the good dose to be start with metformin. Usually we start with small dose with metformin, and we prefer the XR rather than the regular one to decrease the side effect from the metformin. Then we are up titrating the dose as the patient tolerance. So we increase the dose after 2 weeks or 3 weeks as the patient tolerating the medications. Then after that, we reassess after 3 months how much the patient improve after using this kind of medication. There is another question that there is a lot of patients, they are self-stopping metformin or refuse to continue on it because there is having a problem sometimes of the complication post-meals. Always I told my patient to decrease the to decrease side effect from metformin. Please try to take the metformin in between the meals. I mean, in the middle of eating the meals, try to take the metformin rather to take it before, or maybe take it directly after you finish from the meal. So the side effect, it will be decreased or minimized as much as we can. And there is many tools to take this kind of medication. We prefer to take 2 tablets at the same time, but if the patient cannot tolerate, we can split them one in the large meal, another one in other large meal. So in this way, we will decrease the side effect of metformin as lower as we can. There is one question from one of the audience. They said, could we check the vitamins in the diabetic patient in metformin? There's some study talking about some of the patient in metformin, they having decrease in vitamin B12. So to answer this question, yes, we should measure the vitamin B12 every 3 months, or then if normal, if after 6 months, if there is decrease in vitamin B12, we can replace it for the diabetic patient. But it's nowadays is not like before. Now the recommendation, don't give vitamin B12 for all the patients, only for those having deficiency in vitamin B12. So we don't recommend to give it to all the patients. We are highly selected patient to give them metformin. There is one question here about other use of metformins. Metformin is one of the safest medication to use, especially in those patients with pre-diabetes and diabetes. And like other questions, metformin is one of the medication to be approved to use for those patients with polycystic ovaries. Metformin also, the good thing that we can use a metformin if patient not improve, we continue metformin and we add second line therapy, not improve, we add third line therapy. Nowadays we having the many doses of metformin XR. So we having choices to choose between the medication. We have 500 XR. If not improved, we have 750 milligram XR, and we have 1,000 milligram XR. It's helpful for the patient to be taking once daily, and it will increase the compliance of the patient, and it also making the patient taking their medicine better than to take it separate. There is one questions here about metformin and fatty liver. There is any study supporting using this for fatty liver patient alone? Metformin is not the medication that approved for fatty liver patient, but it can be given in addition to other medication to decrease the blood sugar. But the medication that approved decrease the fatty liver or NASH is pioglitazone. Pioglitazone is one of the medication. It's approved to decrease the NASH for the patient having fatty hepatitis. There's one question here. It's common scenarios come to us when the patient having control their blood sugar after using metformin. Should we stop the metformin? The answer for this is no, because the patient is controlled in metformin, not without metformin. So we should continue metformin, even if the hemoglobin A1C, for example, 5.5 or 5.4, because if we stop or increase the dose, the patient might increase their problems, and they will increase their blood sugar. So we should continue in this kind of medication, and we shouldn't stop this kind of medications. I will not forget also in this National Diabetes Day, in this 14 November, that the theme for this year, that how you protect yourself and protect your family. So the diet and exercise and to control the weight is one of the major factors to help our patient to control their blood sugar. It's not only by taking a medicine, also walking at least 150 minutes a week is one of the factors to improve in our diabetic patient, to having a healthy diet, using a lot of vegetable, a lot of fruits is one of the goals to control their blood sugar and their weight, to having mixed meal, just quarter of the meal to be protein, quarter to having carbs, and increase the sessions for vegetable and fruits, and drink water as much as you can. Try to avoid fatty food and fatty oils, and try to go for more healthy food is the key factors to be healthy and prevent your family and your lover one from diabetes. This is the last question for today. They said metformin therapy leading to significant reduction in some of the hormones. So because there is one study talking about that, and how is this true or not? There is also one study they talking about the second generation. They will affect their some of the hormones when they're taking metformin. This study is retrospective study, and it's need to be having another study to support or to decline this. So I know this study having a lot of echo in the media, and the doctors start to questioning the study. So it's need a lot of ongoing studies so to support or to regret this informations. What about GDM using metformin? In our Saudi guidelines or Saudi FDA approval, the metformin is not approved for gestational diabetes. However, in the British guidelines, they approve the metformin to be used in gestational diabetes, but still in our country, it's not approved yet. And also in USD, FDA, they don't approve it yet. But I know in the British, they use it, and it's one of the safest medication to be used. But till now, it's not approved to be used in our country. Thank you so much for your listening. Happy Diabetes World Day. Thank you so much for all our colleague in MERK to arranging this event. And thank you for all the hidden soldier behind this event. I know they are working day and night to make this event successful. Again, happy national or international Diabetes Day, and have a good night. Thank you so much for your listening.